Hello, friends. This is John Finnegan, and we're very pleased today to have as our guest Dr. Arlen Meyers, who's a professor at the University of Colorado School of Medicine, Colorado School of Public Health, and president and CEO of the Society of Physician Entrepreneurs, which we're going to be talking a great deal about today. So, Arlen, welcome.
Thanks for having me.
You're very welcome. So here we are, we're in the age of COVID-19, and the world that we once knew no longer exists. It's pretty profound, and I think of the Kubler-Ross stages of grief that we, as a society throughout the world, that we're collectively grieving the world we once knew. So we're in the process of reinventing a new world. How has that affected you?
Well, it's affected me in several ways, but I want to back up a minute and disagree with what you just said, that, we're in a new world, or I'm not exactly sure how you stated it, like a world we've never seen before, something like that.
Yes.
The fact of the matter is that, unfortunately, in many ways, sure, there have been changes, but unfortunately, we're still in the same world in sick care. The problem is that there were so many problems with sick care and dysfunctions with sick care.
Right.
Waste, inequity, social determinant inequities, supply chain consolidation, lack of, stockpiles, et cetera, et cetera, et cetera. And unfortunately, despite the multiple rules waivers, many of those systems are still in place.
Yes.
And the COVID virus or the COVID pandemic, has simply put a magnifying glass on all those cracks in the system.
Yeah. These are issues you've been calling attention to throughout your career.
Correct. And not just myself, obviously. I mean, not anybody, but health professionals understand, because they work in the trenches, the problems with the system and have been calling it out for years. I mean, the Society of Physician Entrepreneurs was created in January of 2011. And at that time, frankly, myself and others were just a voice in the wilderness.
Yeah.
And now everybody's saying the same thing, but have things changed? Sort of. But the real question is, will the real problems be fixed after the corona apocalypse? Now, to get to your question, how has this affected me? Well, I wear several different hats. So from the standpoint of an educator, I have been teaching online for many, many years, so it really hasn't changed all that much in terms of what's going on. In terms of a provider or an ear, nose, and throat surgeon, I stopped practicing medicine about 4 or 5 years ago, but am now recently going through the process of qualifying to be an online provider for the University of Colorado Hospital Virtual Urgent Care Center.
Thank you.
So I've been providing telehealth and telemedicine, and for many, many years. In fact, your listeners may not know this, but there's a very famous 1924 Time magazine cover depicting the future of telehealth with a doctor in front of a radio prophesying that eventually we'd get video. Well, television happened in 1929. So when people say, gee, all of a sudden people are using telemedicine, this has been a 100-year dissemination and implementation, which is pathetic. So it's been going on for a long time. So from a provider standpoint, I'm just doing telemedicine like I've done for many, many years. From a social entrepreneur perspective, that is helping to create the Society of Physician Entrepreneurs, which is a nonprofit. Actually, we've seen substantial increase in interest
Mhm.
increase on social media engagement, increase on paid membership, and we can discuss why in the rest of the webinar.
Yes.
And from the standpoint of a consultant, which I am, I'm working with several new companies that are eager and interested in taking advantage of the opportunities afforded by the epidemic and looking to accelerate the process of innovation and get ideas to patients.
Mhm.
So I would say in my world, things have ramped up.
That's a wonderful thing. That a pandemic is horrible, but this is an opportunity for very positive change. And it also brings to light the interaction and interdependency that we have in all organizations and parts of society. As an example, business is not separate and apart from society, nor is government. And so these interdependencies are beginning to um, show uh, the weaknesses, if you will. And so there's some opportunities now for us to communicate better and to exchange information and to come out of this with a far better system globally. Would you not agree?
I would agree, but people are people. So
Mhm.
as an example, now the headlines in the news are all about the demographic disparities in mortality in different socioeconomic groups and race classes.
Right.
Um, those social inequities have been around since the beginning of the United States. And the question really will be, will there be any difference after all this is done? Um, I'm, I don't know. I hate to be a naysayer, but I mean, people are people.
Hmm.
And are people going to treat, and really one of the reasons that there's a disproportionate, so, you know, the media are reporting, I haven't seen the numbers, but I don't disagree with it, that there's a disproportionate number of Black people who are dying as a result of the COVID epidemic.
Yes.
And there are many, many reasons for that. One main reason has to do with the impact of social determinants of health and how they disproportionately affect under or underserved populations, particularly Blacks, Hispanics, lower socioeconomic classes, who knows who. So will that change after the pandemic works its way through the system? I'm kind of skeptical unless certain things happen. And we can talk about what those things have to be, but we'll just have to wait and see whether, again, these fundamental flaws in the US economy and social structure are fixed.
Well, let's go back to why the Society of Physician Entrepreneurs exists. You know, you provide educational programs, you're a networking venue, and you provide services. The only ones I'm aware of right now are financial services that you're going to connect uh, entrepreneurs with funding sources. But let's go back to the original why you created this organization to begin with.
Right. So here's the creation story. When I was when I was a professor, an active, academic entrepreneur, surgeon, I was involved, like most academics, with education, research, patient care, community service. Those were the four, or are the four missions of an academic medical center. So I did what everybody else was doing, and you go through the promotion and tenure food chain and publish and perish and all that. Well, as part of the research mission, I got involved with several individuals to make a very long story short, develop a product or a medical device that optically detected cancer in the mouth, because that's my area of expertise, interest, et cetera.
Yes.
Now, without going again into all the issues, what that taught me was, one, that every doctor, engineer, software person, medical professional I know and have taught thinks they have a good idea. I mean, every single person thinks they have a good idea. Whether or not it is a good idea is a whole nother story, but they all think they have a good idea. The second is that they have absolutely, positively no idea what to do with that idea if they wanted to get it to a patient. And the third unfortunate side of the equation was, particularly many, many years ago when we started on this, the people that I just mentioned, engineers, scientists, health professionals, got absolutely no education on how to do it in their formal training. It was just not considered part of their mission. It wasn't what we do. We teach scientists how to do research and discovery. We don't teach them how to build companies. We don't teach this to doctors. We have no business teaching the business of medicine to doctors. We have no business teaching entrepreneurship. If you want to do that, go get an MBA, which incidentally didn't teach them it either. So that was the problem. That was the thing that spurred me to say, you know what, this isn't right.
Yes.
And the medical infrastructure to this day are not going to fix it in the near term. Some are trying. Things are moving along because of what's going on. But in general, most medical schools do not have a program or an interest in teaching medical students or residents the business of medicine, innovation, or entrepreneurship, which is really cruel and unusual punishment because A, everybody's talking about innovation and the innovation imperative.
Right.
And B, everybody's talking about that's how we're going to pay you in the future. Unfortunately, we're not going to teach you how to do it.
Yes.
Which I believe is wrong. So that, in a nutshell, is why we created the Society of Physician Entrepreneurs. It's why we made it a nonprofit. And what we basically do, our mission, our vision, is to close global health disparities. And that's one of the UN Sustainable Development Goals. It's like world peace and gender equity and all these, admirable goals, which are very difficult to achieve and arguably unattainable, but you should try anyway.
Sure.
But our mission to that end is to help our members, and our members are an open innovation network because sick care, that's what I call it, cannot be fixed from inside. It requires outside in, inside out collaboration. And we provide, through a global chapter network, education, resources, networks, mentors, access to experience, peer-to-peer support, and non-clinical career guidance. So when you say, well, the only service you're familiar with is we help connect people to investors, actually, we do a whole lot more than that. And connecting to investors actually is the least important part of our network because most people will never get that far. They need to know, I have an idea, what do I do with it? And so we actually save investors a lot of heartburn because we try to kill a lot of ideas before they even get to that point.
Can you talk a little bit more about those services then?
Sure. So education takes place, as you know, because you've attended several of our Colorado chapter meetings.
Yes.
Both in, prior to the pandemic, most of them were face-to-face chapter meetings. Now we're doing virtual meetings like everybody else. Now, after all this is over, my guess is it will change into a hybrid model. Some will be face-to-face, some will be online, some will be international, some will be inter-chapter meetings. We've already hosted several inter-chapter meetings, which is the last one we did was the head of the chapter in Toronto, Atlanta, Denver, and Barcelona. And so we had an international perspective on the entrepreneurial response to COVID. And I think at least the feedback we got from the people that were online was they liked it and, tell us more. And we want to hear more about this stuff. So I think that our online platforms will evolve and other sort of educational technologies that we're beginning to employ. In terms of mentors and other people that can help you. There are many, many organizations now that are crying for mentors. I just received an email from UCSF, and they put out a national blurb on, if you're involved in this stuff, particularly in digital health, and you want to mentor a startup team, we're looking for people that want to sign on from anywhere. So part of the value of the network are end users, physicians, other people in the value chain who can assist startups in steering them in the right direction or providing them with the right connections or that kind of thing. Other resources we have and offer to our members have to do with internships, connecting people to other companies, steering them in the right direction if they're interested in being an advisor or a consultant, those kinds of things. Peer-to-peer support, particularly now, I think is very important because, as I said, we're growing, but physician entrepreneurs is a pretty lonely tribe. There just are not a lot of them. And there's many, many reasons for that. But the fact of the matter is that it's a small but growing tribe, and they need each other's support. Now, prior to this epidemic, when everybody was, now every health professional is a hero. And God bless them. But prior to the COVID epidemic, and you're beginning to hear some of this now, where were we when we needed you? We were trying to, so the health professionals were complaining and are complaining. You gave us an EMR system that stinks. You made rules that get in the way. You treat us like employees and you treat us like second-class citizens, but now all of a sudden we're heroes. So there's a cognitive dissonance that needs to be resolved. And it may not be politically correct to say that, but the fact of the matter is there are a lot of health professionals that are angry that nobody listened. As simple as that. The
Yes.
administrators, the regulators, the rule makers, the MBAs, et cetera, et cetera. So I think there's going to be collateral damage and a lot of hard feelings when all this is over to patch it up. And it's just another flaw in the system that is persistent and that has been magnified by the pandemic. So it's going to take a lot of relationship mending because there's a lot of bad feelings and people aren't going to forget how you made them feel.
Yes.
And that's going to last.
You alluded to the fact that there's a lot more interest. In fact, people are signing up for SOAP that didn't in the past. And you've spoken to some of these individuals. As an outsider, I see that as a good sign that people want change and are looking for change. What are you hearing from these new members? Why are they joining?
Well, first of all, just to be clear, as I said before, the members of the society are part of an open innovation network. In other words, you don't have to be a doctor, a nurse practitioner, a health professional, or a physician to be a member of the society. It's an open network. So typically our members include, in addition to health professionals, entrepreneurs, service providers, techies, academics, economic development folks, business school people, et cetera, et cetera.
But presumably interested in the healthcare industry.
Well, they are. Otherwise, they wouldn't be members because our mission is to help get ideas to patients. I mean, they could be interested just to hear what we have to say and be what I call online gawkers. And most, in fact, of our social media network, like every social media network, I don't care who is. So we have like approaching 30,000 people on our LinkedIn site and lots on Facebook and all over. The large majority of those people on those sites are gawkers. They're in, and I don't mean that disparagingly or to be pejorative. I simply mean they're there to just follow what's going on, maybe garner some information, just keep track. see whether they're fully informed. And there's nothing wrong with that. That's fine. Then there's a smaller group, about 10%, that are the walkers, and the talkers rather. And the talkers are, when you look at people who comment on social media posts, about 5% of the membership do 95% of the talking. So you really get a skewed view, and most of the time they're biased and they have an axe to grind or whatever. So you have to be careful when you look at who's posting what on social media sites. But the more important ones are the 1% who are actually the walkers. In other words, they're walking the talk and they're actually doing something and trying to get an idea to a patient. So when you look at that funnel, the impact that we create, the most important key performance indicator is, did you get an idea to the patient that added value, and in some small way, maybe soap contributed to that happening? Now, when people say to me, well, what has soap done? We haven't done anything. All we do is create a dating service so people can collaborate and make babies. That is, inventions, discoveries, devices that they can eventually get to a patient. So that we're basically just a dating service. I tell people we're a cross between Rotary and Match.com. Mm-hmm. We have not-for-profit chapters all over the world. We're a dating service that allows people to connect and compare ideas and move ideas forward or kill them.
Well, I think you're much more than that. I've received such tremendous value in the last year that I've been a member, and I think too that this exchange of information is vital. Take, for example, at a global level, when China in January, did they not provide the genome for COVID-19, for the coronavirus itself? And which now scientists are using that information to examine treatment methods and a potential vaccine. Is that an example of good communication?
Well, yes, but I mean, that's part of the scientific ethos. I mean, if you get rid of the geopolitics, science is about sharing truth, or what serves as the truth in that moment in time, until we discover something that changes the truth.
Right.
But the point is that the scientific ethos is scientists share information. So that's why we have international journals and conferences and whatever. So you could share this information. It's part of the drill.
Right.
And that still, to a large extent, persists. I mean, it's part of medicine. It's part of science.
Right.
You share information. Now, obviously, some of it has been politicized, and that's unfortunate. But when you take, for example, if you look at the influenza epidemic in 1918 and compare it to the technologies that are available today versus the technologies that were available then, I mean, I think it's pretty incredible that someone can identify a virus, they can basically identify the entire genome of the virus, they can create a test for the RNA transcription to the DNA and detect it in a matter of days, mm-hmm. like weeks, and for a relatively small amount of money. I mean, that's pretty incredible, but that was the result of 20, 30 years of genetic technology and Human Genome Project and PCR and all the other stuff that sort of followed along. So in a lot of respects, of course, it's more important than ever that information be exchanged. So the global care community can help each other. And it's another point that, as I mentioned before, there are serious cracks in the system that persist. And one of them is the lack of a global care ecosystem. Everybody's got their own silo. Everybody's got their own way of doing it. Everybody has barriers to sharing information, including the United States. This whole issue of EMR interoperability, who shares what with whom, who owns the data, et cetera, et cetera, et cetera. So we have a long way to go to fix this. Mm-hmm. And whether this sense of urgency will create lasting change remains to be seen. I think the most critical pieces that have to happen for there to be lasting change, probably to me, the single most important thing will be, will the rules, regulations, and laws that have been expedited or waived stay that way, or will they revert back to the way they were before? Because rules create ecosystems, ecosystems create business models, and business models either facilitate or inhibit the development of innovation. The core, the root cause of all of this business derives, in my opinion, from the rules. Who pays for what, reimbursement, business models, who can see whom, credentialing, scope of practice rules, cross-border telemedicine rules, national medical license rules, et cetera, et cetera, et cetera. So we'll just have to wait and see. But I said this wouldn't be the first time that there was an incentive to change and it reverted back to the ground state. And I just saw a curve, the flattening of the curve.
Yes.
Or the comparable when will the economy recover curve. And the beginning of the curve was the base state, like where we were before the epidemic.
Yes.
And the end of the curve, best case, was exactly the same base state, which I think is ridiculous. I mean, the whole point of this is to not be back to the base state. We don't want a third of individuals making appointments that are unnecessary. We don't want people having unnecessary surgery. We don't want people spending money on things they shouldn't spend money on. We want people to be smarter about their health. We want a healthcare system, not a sick care system of systems. Mm-hmm. So if we are to if we don't take advantage of this opportunity, first of all, it would be horrible to the people that have died. Yes. And secondly, it would be a criminal waste of a crisis.
Something you said recently really resonated with me, and I'm paraphrasing, but as I understood you're saying that the positive change that's going to take place within the healthcare system cannot be done within. And so what I envision is a room in which to the right of you is someone from manufacturing, to the left of you is someone from distribution, from looking through different lenses. And when you state a problem clearly, that those individuals can help you. And hand in hand with that is this business about healthcare is being unreachable by the average citizen. And I think of Siddhartha Mukherjee, the author of The Emperor of All Maladies, now with his book, The Gene, being so popular, and it's now a special on public television. That makes a guy like me, who's a non-medical professional, it makes science and medicine accessible, because Siddhartha Mukherjee does it with stories. And it goes back to this fundamental need and ability that we all need, which you have in abundance. It's an ability to communicate. So I've thrown a number of ideas and questions at you really at the same time there.
Right. Well, I think my tag, my little snippet or soundbite is that sick care cannot be fixed from inside.
Yes.
In fact, it's been demonstrated repeatedly that almost no industry can be fixed from inside. I don't care whether it's aerospace, financial services, you name it.
Because we become myopic?
For a number of reasons, but the main reason is because when you look at where innovation or the next great idea comes from, it rarely comes from inside. Despite the conventional mythology, there are very few aha moments. It's a series of iterations, and it's particularly true in medicine and science. You know, this old stand on the shoulders of others. It's a cumulative process.
Right.
It's very rare. And, oh, by the way, when there is an aha moment, then the likelihood of it ever reaching a patient is slim to none, and usually takes an extraordinarily long period of time. The typical number cited, the recited number, is 17 years for a discovery to eventually get to a patient. And if you look at, for example, the famous Fleming discovering penicillin on the little molds,
Right.
well, the fact of the matter is, he did that in the 1920s. It didn't get to American soldiers for the first time during World War II until the 1940s. It took 20-something years
Yes.
to get penicillin in a form at scale to people. And it was only the Second World War that accelerated it, much like what's going on now.
Yes.
And there are numerous examples of that. The stethoscope. I mean, it just goes on and on and on and on. So there's multiple barriers to dissemination and implementation. There are multiple barriers and resistance to change. So the point is, it can't be fixed from inside, and it has to be collaborative on many dimensions. It has to be collaborative between industries. For example, we wouldn't have telemedicine if it weren't for the space program. It wasn't some doctor that invented telemedicine.
Right.
It was the space program, amongst everything else. GPS and all the stuff we're using now had nothing to do with a medical scientist or a doctor inventing it. It came from another industry. So there has to be inter-industry collaboration. There has to be inter-functional collaboration, which you just alluded to: manufacturing, engineering, sales and marketing, research and development, clinical testing, et cetera, et cetera. There has to be demographic and diversity collaboration, whether that's psychographic collaboration, whether that's demographic, diversity, equity, and inclusion. So we just all have to play nice together better if we want to get anywhere. Mm-hmm. And another crack in it, or a fly in the ointment, has been the problem with physicians, scientists, engineers early on being part of the product development and business model testing life cycle for big tech, big pharma, big digital. We've been excluded for too long. And it's another thing that we've been talking about over and over and over. And now all of a sudden they want us to be their best friend. You know what? People don't forget how you make them feel. So again, it's another thing that we're going to have to resolve. And how do we grease the skids? Because all you have to do is look up McKinsey, and the latest article is, what will big tech, big pharma, big digital look like post-virus or post-COVID? And all the things we are discussing are part of it.
Mm-hmm. You know, I want to be respectful of your time. And I think as we wrap this up, I want to ask you, first of all, are there any questions that I didn't ask you today that I should have? Any points that you'd like to make about your mission and about the situation that we're in today?
Well, the main point that I would make, and it had to do sort of with the social entrepreneurship title, the main point that I would make is that people misinterpret the definition of entrepreneurship to mean people creating businesses. And in my view, that is a very limited, self-defeating definition. So my definition, which takes into part parts of other people's definitions, because everybody's got a different definition of entrepreneurship. My definition of physician entrepreneurship is our health professionals, like I said, it's an open network, but let's just say health professionals who pursue opportunity under what we call VUCA, or what others have called VUCA conditions: volatile, uncertain, complex, ambiguous, with the goal of creating, and this is the important part, with the goal of creating stakeholder or user-defined value through the deployment of innovation using a viable, or what I call a vast business model. Now, that's a complex definition that has 5 or 6 parts, but the point is that there are many, many, many ways for people to create user-defined value through the deployment of innovation other than creating a company or building a product. So as it applies to physicians, they could be private practitioners running an office. They could be technopreneurs trying to get an idea or a discovery to a patient. They could be an intrapreneur, an employed physician trying to add value to their organization. They could be a social entrepreneur trying to improve the human condition, typically through the creation and deployment of a nonprofit organization. They could be a service provider. They could be a physician investor. They could be an edupreneur, an educator in somewhere trying to innovate, particularly in these times. How do you do a better job of educating when you can't see students face to face? Now, I've had the good fortune of wearing all of those hats, and including a private practitioner seeing 30 patients a day for 40 years. Yes. I'm not saying that's the wrong thing to do. That's what doctors do. I'm just saying there are a million other ways to skin the cat and satisfy the definition of physician entrepreneurship, one of which happens to be social entrepreneurship, and that's what we do at the Society of Physician Entrepreneurs.
Well, Dr. Arlen Meyers, you are a tremendous leader. I know you to be a great leader and a great communicator because I've had the opportunity to participate in your organization for more than a year now. And I just want to say thank you for the work that you're doing. I think it's extraordinarily timely today. We need that which you do. And if there's anything that I can do or our audience can do to help your organization, I hope you'll let me know.
Well, thanks. That's very kind of you to say that. But I really want to say that the success of our organization really has to do with the community. And if I could just make one parting, I mean, I've learned a lot doing this because I had no clue what I was doing when I started all this.
Sure.
I was one of those doctors that was clueless. I mean, I had an idea. I didn't know what to do with it. Nobody was teaching me. I had to go out and kind of do it myself and take all the arrows and make all the mistakes and, that kind of stuff. So,
right.
So one thing I learned when we created the society, I had zero experience. I mean, I'd been on little, boards and, participated in other nonprofits, but I had never actually created and scaled one. And so I've learned a lot over the last couple of years. And what I've learned is that the success of the organization at some point, and this has to do with a lesson in leadership that I don't know if it's a lesson, it's just what I've observed is, at some point, you need to kind of move away from the front of the class to the back of the class. And by that, I mean, there are times when you should lead from the front, and there are other times when you should lead from the back. And the visual is a sheep herder. So if you've ever seen sheep herders with the cane, they lead from the back. They herd the sheep forward from the back. Yeah. And I'm not saying that our members are sheep. What I'm saying is that at some point, once you have energized the organization and created that momentum, you need to get out of the way and lead people from the back. So if they tend to steer off the road, you get them back in the middle of the road, but fundamentally they're going forward and they're finding their own direction. And that's where I think then you begin to see scale. Because now, again, to use the analogy, sheep like to herd, and they find other sheep that are like them. And eventually you develop this network and tribe effect that accelerates the growth of the nonprofit.
Well said. Thank you for your leadership, and please stay safe.
You too. Thanks a lot. We'll see you hopefully sooner than later at the next face-to-face chapter meeting.
Thanks, Arlen.
Bye.